Hi, this is Dr. Dega, and I would be taking you on the NAC OSCE tutorial for asthma and foreign body. So, imagine a case scenario where a patient with difficulty breathing started a few hours ago. So, you're being asked to take a focused history and do a physical examination. What are the expectations for this station? So, you would have 2 minutes per encounter, 8 minutes to take a history and do the physical examination, and 2 minutes to answer post encounter questions. So for the station, the task here is to take a history, have differentials, and your working diagnosis, as well as answer questions as regards your investigations and precise management. You're being tested on your communication skills, your physical examination skills, and interpretation of results that would be given to you if available. For your 2 minutes per encounter, don't just stand and think. Spend the time to understand the task, note down your possible differentials. You should have about 3 to 5, and then write out the format you're going to be using to take your history to make it better organized. You should write specific task that you really do not want to miss or forget. And then you should make sure you answer questions such as the age, the gender, the causes, and possible red flags so you don't miss that. What could this be? That question would help you arrive with your differentials. For this kind of case, it could be a problem having to do with the respiratory system, the cardiac or cardiovascular system, and then other systemic causes as well. It could be asthma, foreign body aspiration, pulmonary embolism, infections such as pneumonia, bronchitis, and COPD as well, exacerbation, as well as hemothorax and pneumothorax. Congestive heart failure, arrhythmia, angina, myocardial infarction, and pericardial tamponade or effusion could also be causes. And anaphylaxis, panic attack, anemia, and hyperventilation syndrome are other systemic causes that could cause difficulty breathing or dyspnea. So at the 8 minutes with the patient, what do you do when you go in? First of all, you should wash or sanitize your hands, introduce yourself. You should be brief about this, confirm the name and age of the patient, and find out why the patient is at the clinic that day. You go right into taking a history of the presenting complaint using the format in the slide. So you start with the onset. You should get more details, understanding the frequency and cause of the difficulty breathing. What were the preceding events to the onset of the symptom? What exactly was the patient doing? Was the child playing with toys? Was the patient exercising? What exactly was going on? Was the patient at work? And are there associated sounds on breathing? And if there's any sound, you should characterize the sound. What kind of sound is it? Are there associated cough? Is there associated cough? If there is, how frequent does it happen? What makes it worse? What's the character? Is it productive? If it's productive, what's the color, the quality, the quantity? And are there any smell? Is it bloody or not? Is there any associated chest pain? And if there is, you should characterize the pain using the OPQ-RST format. That's for onset, position, quality, radiation, the severity, and the timing. You should find out if there are any worsening factors to that worsens the difficulty breathing, or anything that makes it better. Is there any history of trauma? And are there any associated leg swellings? If there is, does it resolve or is it always there? Is there associated orthopnea or paroxysmal nocturnal dyspnea? Does this difficulty breathing affect the patient's sleep? Any recent flu-like symptoms? Any recent history of travel or long trip to rule out pulmonary embolism? And you should ask questions to rule out red flags. So this could serve as your constitutional symptoms: fever, night sweats, weight loss, loss of consciousness and syncope, chest pain, particularly if it's referred to the arm or shoulder, and hemoptysis. You should find out about past medical history such as asthma, COPD, hypertension, or other cardiac risk factors, heart failure, malignancy, and if there's any previous history of DVT or pulmonary embolism. So, a past surgical history would definitely let you know that there are underlying causes, and if the patient is on any medication such as bronchodilators, OCPs, antihypertensive, blood thinners, cancer medications, immunosuppressants, all of these would help point you to possible differentials. And immunization is very important for infectious causes. If the patient is female, you should ask about the obstetric and gynae history, find out about the last menstrual period, what are the possibilities that the patient could be pregnant, and any previous gynecological history. You should find out if the patient has had any recent hospital admissions, or if the patient has been exposed to someone who's been sick recently. Finding out about medications, food, and environmental allergies would help you as well. And family history of chronic conditions like asthma, allergies, hypercoagulability, myocardial infarction, cystic fibrosis, malignancy, and alpha 1 antitrypsin deficiency would also point you in the right direction. The patient's occupation would expose possible risk factors and let you know if the patient is at risk of certain causes. Social history, particularly focusing on the smoking. If the patient smokes, what's the quantity and for how long has the patient been smoking? And for alcohol, you also have to do the same thing. How long has the patient been taking alcohol? How much and what type? Does the patient has the patient ever tried recreational drugs? And what are the living conditions? Here you have to be certain about the partners, family, relatives, and social support system, as well as finding out if the patient has any social stressors or possible causes to rule out a panic attack. How's the patient doing? How do they support themselves financially? And how do they feel generally? You have to find out about the family and living conditions if it's a minor, understanding um, the situation at home, and if this child is being taken care of, particularly in a situation where you're suspecting foreign body aspiration. Why did that happen? Was the child being watched, or is this child being abused or being neglected? Now, for the review of systems, this would help you check if you missed out anything in your history. Most of the questions are things that you would ask in your history of presenting complaints, but going through them will help you check if there are anything you missed, like asking for lumps and bumps in the constitutional symptoms, as well as asking for fever, for chills, for palpitations, for skin rash, joint pain, or any sort of bleeding from any part of the body. So you go right into the physical examination. Here, you just have to follow the inspection, percussion, palpation, and auscultation format. This would help you work systematically and you would be better understood as you go. Before you start this, find out if the vitals are available, and if they were given at first, you could find out if it had changed since the patient presented. For the general examination, you check if the patient is pale, check if the patient is in any painful or respiratory distress, check if the patient is tachypneic, if the patient is dyspneic with nasal flaring, probably the patient is not able to talk and say full sentences, or if the patient has increased work of breathing. Is the patient taking the tripod position, or is the patient looking cachexic? And is there any stridor, particularly in children who probably aspirated foreign a toy or something into a foreign body? And then basically you do the airway, breathing, and circulation assessment, particularly if the patient is in the emergency. You could assess the vitals if it's not been given. For the examination of the extremities, you inspect for urticaria, for rash, finger clubbing, and check for limb asymmetry or swelling and acrocyanosis. Palpation, you check for capillary refill to rule out pallor, and then check the radial pulse rate. You check in the rhythm, is it regular, and is it symmetrical bilaterally? You check for clammy skin, calf tenderness, and measure to confirm the size as well. You check for pedal edema to rule out any swelling. And for the head, eye, ear, nose, and throat examination, you check for facial or lip swelling. You assess for central cyanosis, asking the patient to lift the tongue to the roof of the mouth. And then you check for use of accessory muscles as well around the neck. You check the mouth for any signs of foreign body, especially in kids. And for palpation, you check for the tracheal deviation and check for lymphadenopathy. You assess the JVP and hepatojugular reflux to see if there's positive cosmal sign, which could point you to um, things like constrictive pericarditis, restrictive cardiomyopathy, massive PE, and right congestive heart failure that would have paradoxical rise in the JVP, especially with inspiration. On auscultation, you listen for carotid brew if there is. And for the chest examination, you check for scars, check for deformities, and such as barrel chest and in COPD, and check for signs of respiratory distress. You palpate for differential warmth, deformities, and tender points that could be found in musculoskeletal cases. You check for chest expansion and tactile fermenters, and you could percuss for check for hyper or hyporesonance. On auscultation, you listen to all the lobes, comparing both left and right, and you comment on the air entry and the presence of wheeze, crackles, crepitations, stridor, bronchophony, or egophony. You check for pacemaker scars or visible pulsations, and you assess for apex beats, palpable chews and hips to assess the cardiovascular system. You also listen for the heart sounds and if there are any murmurs. For investigation, this would be around the post encounter usually. You would explain the investigations you would be doing, which would be the complete blood count with differentials to rule out any infectious causes. Check for the serum electrolytes, the blood urea, nitrogen, and creatinine, as well as serum glucose, troponin, creatine kinase, arterial blood gas, and D dimer. For the imaging, you would want to request for a chest X-ray and ECG, and then a pulmonary function test and metacolon challenge test could be done when the patient is stable to confirm your diagnosis if you're suspecting asthma or COPD. And for the management, if the patient is in the emergency, you want to be sure the SpO2 is greater than 90. If less, you could give the person oxygen and intubate definitely the patient's GCS is less than 8. Medical treatment for patients with asthma basically would give them intravenous corticosteroids and nebulize with a bronchodilator, then reassess when this is done to assess for improvement. And this such patients should have follow-up visits to be sure that everything is fine. This patient should have psychosocial supports and counsel on asthma exacerbations, what to do, what to avoid to prevent triggers, and as well as counseling on safe play practices for kids in the case of foreign body aspiration. For a patient with asthma, could want to, or a patient with panic attack, you could want to educate on breathing control exercise and relaxing or coping strategies, as well as considering referring to the psychiatrist or the psychotherapist. Thank you so much for listening to my presentation. I hope you find it helpful.